Good evening to our audience. My name is Xu Zhaojun. Good to see you again. We're now in a hotel in Wuhan, the epicenter of the coronavirus outbreak. And together with me are three doctors from the Peking Union Medical College Hospital. They have been working here in the city, in the hospitals in the city for almost a month. And today they will have another cross-nation medical consultant meeting with their colleagues from Canada. Okay, we don't have much time, and I will try to save as much time for these doctors. And I will now give the floor to you and to introduce yourself, okay? And so as to our colleagues from the Canadian side. All right, the floor is yours.
Good evening, everyone. I'm Jing here from the Department of Infectious Diseases of UMC Hospital. I do clinical research on infectious diseases. I come to Wuhan for almost 5 weeks. I provide point-of-care testing for our medical staff and also our patients.
Hello, I'm Dr. Wu from Peking Union Medical College. I'm a cardiology doctor, faculty of American College of Cardiology. And now I have been staying in Wuhan for about 3 or 4 months and take care of the patient and do echocardiography and investigate the mortality, cardiovascular complications of this patient.
Hello everyone, I'm Dr. Jing from Critical Care Medicine, Peking Union Medical College. I have engaged in the treatment of critical care patients for more than 10 years. And now I'm in Wuhan for about 5 weeks. And I'm an attending physician and responsible for the treatment of the critical care patient.
Okay. Maybe I'd like to take a few minutes just to introduce our team, because the whole national team from Peking Union Medical College consists of 185 members, including 44 doctors, 132 nurses, 3 laboratory technicians, and 5 directors and secretaries. We take care of the patients in a new built intensive care unit in Wuhan. And in the last 6 weeks, we have admitted more than 100 patients.
Okay, gentlemen from the Canadian side, Doctor, do you think it's okay for them to raise their questions?
Yeah.
Okay. So, gentlemen, we're ready to have your questions. If Dr. Behr would like to speak first, please do.
Hi, do you hear me?
Yeah.
Yes.
So as clinicians, I'm a clinician. I'm the chief of infectious disease at one hospital here. As clinicians, I would like to know what are the 3 most important lessons you have learned. And since there's 3 of you, this makes it easier. I can ask you, for each one of you, what is the single most important lesson you have learned in the past 2 months? Please.
I'll give my answer first. For me, I think the most important thing is they are identifying each infected cases. Actually, today there is a paper published in Science support my opinion. It is estimated that 86% of all infections were undocumented infection prior to the Wuhan travel shutdown. Per person, these undocumented infections were 55% of the contagious as documented infections. However, these unidentified infected patients was a infection source for up to 79% of documented cases. So these findings explain the rapid spread of COVID-19 and indicate containment of this virus will be particularly challenging. What we have done in China and in Hubei province has shown that if we detect, treat, isolate, trace, and mobilize people in the response, we can slow the virus and can control the epidemic.
Okay. So my experience is that we need more doctors and nurses, healthcare providers, to get the experience of intensive care unit. Because I think not all the doctors or nurses got this kind of train. Like in PUMC hospital in the last 2 decades, ICU rotation is considered and involved in the resident program and the registered nurse program. So that's much helpful for our team members, our staff, to work in the ICU in Wuhan. But I think in China and in all over the world, we need more healthcare providers to get the experience of ICU.
Okay, and as I'm an ICU doctor, I think my experience is respiratory support is very important for these patients. And if these patients have dyspnea, you have to give them some oxygen. And if standard oxygen therapy is not work, maybe high flow nasal catheter or non-invasive mechanical ventilation should be started. And if the patient's symptoms didn't relieve, I think timely intubation is very important to protect the lung. And we think respiratory support is very important for this patient. And if you want to intubation for protect the lung, you have to do immediately.
Thank you. So then I wanted to have 3 more questions. And since there's 3 of you, again, I can ask you each to give me, what do you each think is the single most important unanswered question? Something we do not know that we need to know.
Oh, okay. I will answer first again. I think we have unresolved problem with the diagnosis technology. Now I think diagnosis of the COVID-19 is a comprehensive and dynamic process, rather than rely on certain type of lab test, like PCR for nucleic acid of the virus, because each method has its own strength and weakness. So neither the PCR nor the antibody test can give us the optimal result for the diagnosis. So we need to take into account of the clinical manifestation, epidemiological history, CT scan, and lab test. Yeah.
Okay. So my unanswered question for me is, what is the long-term prognosis of this patient? Because we do save lives in the ICU, and the patient got cured and is discharged or transferred to the general ward and get home. But I don't know what is the long-term prognosis, because you can see the fibrosis in their lung from the CT scan. And I don't know the COVID-19 will be like the flu A, flu B, like could be the last for a long time, and it could be a seasonal disease, or it could be cured like SARS and disappear in quite a long time.
Thank you.
Okay, and my answer question is, which kind of antivirus therapy is efficient for all these patients? Because as we know, in our protocols, many antivirus therapy was suggested, but we don't have any evidence of these patients, especially in the critical ill patient. Maybe which kind of medicine or which kind of therapy is more effective for this patient is a hope, maybe, or is a powerful method to cure more patients.
Thank you very much. I will let other people ask the questions. This is very much appreciated, and I will listen for the next 16 minutes. I very much value your wisdom.
Can I be the next one? Because I also have to go. This is Dascal. I'm the Chief of Laboratory Medicine for the McGill system, 15 labs, 15 different hospitals, and I'm an infectious disease microbiologist. My questions are two. The first one is, tell us about treatments directed directly to SARS-CoV, Kaletra, lopinavir, for example, ritonavir, chloroquine, etc. And the second question is, how do I get access to your point-of-care tools? In other words, what treatment experiences have you had?
Okay, just as I said, yes, the antivirus therapy is one of the unanswered questions because all these suggested drugs in our own clinical practice, none of them showed very, very good efficiency, and maybe our patient is critical care patients, and some of the drugs didn't give their didn't manifest as very powerful for this patient, but till now we don't find any very good antiviral therapy, and none of these drugs are very powerful in the critical care patients. Maybe in some patients who are not so severe, or we say the mild patient, some of the drugs can be effective, such as Abidol, chloroquine phosphate. But in the critical care patient, we didn't see any effective. And the second question, I will say something about point of care. In our ICU, Dr. Wu just said that we have some point of care machines, such as we have the CRRT machines, we have ultrasound, and we have the ABG, arterial blood gas. All these point of care machines can provide us much information about this patient.
And some patients got the antivirus therapy from a clinical trial, but mostly they receive the medication from, when they are mild or moderate ill patient, and not like critical ill. And the point of care is, interestingly, we doctor do the ultrasound, checks X-ray, blood gas by ourselves. Yeah, we are multiple.
So it's not an actual PCR point of care that you're discussing?
Oh, excuse me. Regarding the point of care testing for the COVID-19 specific service, we actually provide two types of the lab test. The one is the PCR for nucleic acid of the virus. It will take 1.5 hours. The other one is the antibody test, the IgM and IgG antibody test. It will take only 15 minutes.
The IgM test, was it positive in all the patients early on?
Usually, the IgM will be detected in 3 to 5 days after the disease onset.
Okay, just as I expected. Is there any way you can email me the RT-PCR information that you have? That would be appreciated.
Okay, if we can get your email address. We are happy. Okay.
That's it for me for the moment.
Hi, this is Matthew Cheng. I'm one of the infectious diseases doctors and medical microbiologists at the MUHC. I'm also on the trial steering committee for Canada's nationally funded treatment trial for COVID-19. First of all, I'd like to thank you very much for your time and your expertise. We sincerely appreciate it and can benefit from your past experiences. I'd like to follow up on one specific question about the benefit of treatment, particularly in patients who have severe or critical illness. My question to you would be if do you think we should treat all patients regardless of severity, including those with very minor disease? My second, oh, maybe we'll just start with that. That'll be my first question for now.
I will give my opinion first. In my opinion, for the mild cases, we actually to provide quarantine services for them. It's for the epidemic control rather than treatment. But for the severe cases, it's definitely we need to provide comprehensive supportive care for them as early as possible.
My opinion is I don't think the antivirus therapy is very effective in the critically ill patient, because we need extremely strong life support. You know, if the patient get a septic shock, get a hypoxia, a lot of things could affect the final result of the clinical trial of the antivirus therapy in this kind of critical ill patient. But in mild patient, I think we need a very well-designed, controlled, double-blind study.
Thank you. That's very helpful. On that note, were you able to pick up on any early markers to predict patients who would become very sick, very critically ill, and would require that extraordinary supportive care?
Yeah. Okay, I can answer this question first. Because I'm a cardiology doctor, there's a lot of cardiovascular complications in this patient. I have investigated about 77 patients and trying to find out some biomarkers. Interestingly, and we do have some. We can get from the lessons of the previous ICU experience, like high sensitivity cardiac troponin maybe is one of the important biomarker of the all-cause death and the cardiovascular death. There is some difference, but we need further investigation. Is like thrombocytopenia, lymphocytopenia, elongation of the PT, and the elevation of D-dimer, maybe, but I didn't finish the statistic analysis yet. I think
May I ask a question from here?
Yeah.
It's Peter Goldberg. May I ask a question?
Yeah. Go ahead.
Yes. Why did the patients die? What did they die from?
Most of the patients die from respiratory failure. And to our surprise, most of these patients have hypoxemia. And also their carbon oxygen concentration is relatively high. Maybe the highest of our patient is over 100. And we think for this patient, the lung lesions of this patient, maybe most of them are interstitial changes, and the ventilation was affected for this patient, and you can't control these hypoxemia or high hypocalcemia. So this patient suffered from respiratory failure for most of these patients.
I think three most important cause of death is septic shock, and respiratory failure, and cardiovascular complications. Top three.
Dr. Goldberg, are you with us? Oh. Something's wrong with the with the internet meeting
Okay.
app,
Connected.
I think that will be fixed
You think we
in a
lost the
couple of
audio
minutes.
from our
Oh yes,
hosts?
they're coming back. Are they coming back? I don't know. Oh yes, they're coming back. Yes, yes. Okay, Dr. Peter Goldberg, are you with us?
Yeah, yeah.
All right,
Do you hear
great.
me now?
Okay, we were offline for a couple of seconds, and okay, please continue
Okay.
with your dialogue.
Have you?
When the patients who survived, how long was the usual duration of mechanical ventilation?
It's
10 to 14 days.
I think from the onset of the symptom to intubation, it's about 2 weeks. The mean duration is 2 weeks. From intubation to discharge or to stop ventilation is usually 10 days to 2 weeks.
Okay. Okay. And my last question is, how often, or what was the prevalence of the myocarditis? We're getting some reports from some case in Seattle of a patient getting better, and then he had myocardial failure, cardiac shock, cardiogenic shock. Has that been a problem, either early or later in your patients?
That's my question. Okay. So we analyzed all dead patients, and I retrospectively investigated their data. We do have 3 patients with cardiac shock, but it's not at the beginning of the disease, but it's at the end of the life. And before that, the echocardiography of these 3 patients is fine. In 2 patients, and then another patient had previous myocardial infarction. So, in my opinion, there's no evidence of the viral myocarditis in COVID-19. No evidence.
Okay, thank you.
Okay, maybe I can ask a question. And I'm aware that a number of autopsies has been done in China. How does this pathology findings guide or change your clinical management in the patients?
Okay, we have some. Last week we have the CPC with the pathology doctor, and we get some information from this pathology doctor, and they published recently, just yesterday, in Chinese Journal of Pathology, the 3 cases of autopsy. The most finding is, I'm not a pathology doctor, but I can read something for you, okay? So, sorry. I think the most important finding is focused on the lung. So they say the various damage were observed in the alveolar structure with minor serous exudation and fibrin exudation. Hyaline membrane formation was observed in some alveoli, and they can see some infiltration of immune cells, and the majority of this infiltration is macrophages, monocyte, but not lymphocyte or neutrophils. And they do the RT-PCR in the lung tissue and find the positive in this tissue, but they still do the RT-PCR in the heart, in the spleen, in the kidney, and in this organ they are all negative.
Okay, thank you, Dr. Wu. Can you spare me just a few seconds? Let me read something to our audience on the internet. Okay, so now more people are get onto our website on the Facebook. And what I would like to say to our audience, do you have any questions on COVID-19 for the doctors? They share them with us on Facebook using My Opinion on COVID-19. Okay, let me read it again. Do you have any questions on COVID-19 for the doctors? The doctors are with us. Share your questions with us on Facebook using My Opinion on COVID-19. Thank you very much. Go ahead, please. Thank you.
Does those pathology findings help you to change your management strategy, or does that?
Yeah, I can mention one thing is from different autopsy. Like one patient, you can find a lot of mucus effusion in the bronchus, but in another patient, you can see nothing, not so many sputum, not like highly membrane. So patient to patient is different. But in my belief, what makes this such a big difference between two patients? Because one patient got non-invasive ventilation, and the other patient got invasive ventilation and live longer. That's the critical difference. You got different findings in pathology.
So I guess I'm next. My name is Paul Warshawski. I'm the director of the ICU at the Jewish General Hospital, which is the designated hospital for COVID patients for half of the province of Quebec. So far, we have 4 patients in our ICU. My number one question is, obviously this is a novel virus. If the patients that I had the flu, I would predict that they would survive based on what I'm seeing. So 3 of them are intubated, they're on moderate amounts of oxygen, 1 of them is requiring proning, but is doing well with proning. I'm wondering if you found that adjusting for the severity of illness at any point in time, did the outcome seem to be what you would expect to see with other viruses?
Okay. Can you hear me?
Yes, I can hear.
Okay. In our experience, this COVID-19 virus, this COVID-19 disease is different from that of other flu. Just as I mentioned, we have many flu patients every winter, and most of them didn't develop such severe air deaths like these COVID-19 patients. And we found that in these patients, the prone position ventilation is not so effective. But in the patient suffered from flu, the prone position ventilation is more effective than these patients. Maybe we think the pathology of these 2 viruses, they have different effect on the lung. But what's the difference? And what kind of therapy can we do? We don't have that very good suggestions. But if you found that your patient can recover, soon, and as your past experience, maybe this patient is not suffering from this kind of disease. But I think maybe lab test is very important. So you can just first differentiate from the flu and differentiate from the flu and the COVID-19 virus. And maybe at first it is very important.
Somebody had mentioned that in your experience you weren't seeing cardiac involvement, and yet the reports that we're getting from Seattle, they seem to be very concerned that their patients, after recovering from a respiratory point of view, then go on to have cardiovascular collapse from what seems to be a severe myocarditis. Any comments on why you have a different experience from what they're describing?
I do not exclude case report. I just report the experience in our team, my experience from 77 patients, that I don't think, even the patient from Seattle may have myocarditis. This is not quite a common phenomenon. This is my opinion. And the second thing is, most patients in our ICU, because it's a quarantine ICU, so it's not applicable for the patient to transfer to receive the cardiac MRI, I mean magnetic resonance, to have the evidence of the myocarditis. And the second thing is, I have discussed with the pathology doctor, and they tell me that they do like maybe 10 cases of autopsy, and from the pathology of the myocardium, in these 10 patients, they didn't find the evidence of myocarditis. Okay, that's my personal experience.
And I have something to share with you, because as we know, several of the ARDS patients, they will develop right heart dysfunction. Maybe we say that acute core pulmonary. And in our findings, the percentage of ACP in this patient are relatively high. In the paper, before, about 20 to 25% of patients, ARDS patients, developed ACP. But in our patient, about 50 about them developed ACP. And maybe that's one of the reasons of the cardiac collapse in these other hospitals.
The other thing that comes to mind is that one wonders whether some of the medications that they're giving to people with very little evidence are actually resulting in an unexpected side effect. But I don't know how they've been treated them. But the reports from Seattle were that this was a very frequent outcome for patients who had recovered from mechanical ventilation. So it's surprising to see that you guys with the most experience didn't have the same impression.
I do have experience of side effect of the Remdesivir, because the patient got acute kidney injury from taking this kind of medication, and we stopped this, and the kidney problem got fine.
I think that's an interesting lesson.
Do you remember which medication it was that caused the AKI?
I think that it's Remdesivir.
Yeah.
Interesting.
Because the patient is in the clinical trial of Remdesivir.
When are you doing the interim analysis on the Remdesivir? When will you be doing the interim analysis for the trial, the Remdesivir trial?
Okay. Because we are not the
We are not the site.
PI. We are not the PI.
And
I think
we are not included in the clinical trial, so we don't know the answer.
Is he mentioned the Remdesivir?
Yeah.
Yes.
Okay. I think I can I can answer part of your question. Some other doctors, the doctors from another hospital called China Japan Friendship Hospital, they are doing the test of that medicine you mentioned as Remdesivir. But I know the vice president of that hospital is in charge of that testing. But so far, I haven't got any result from the vice president of that hospital or anybody from that hospital. But I know that they're still doing that.
Okay. If they do an interim analysis, would it be possible for you to email Dr. Gao the interim result? So we get it before publication?
I think that we will open the share the experience and share the result before the publication. You can see from the...
Would appreciate it.
Yeah.
Okay. Okay, gentlemen, if you don't have any questions at the moment, would you spare some time for the people, for our audience? We know that the hundreds of thousands of people are watching this live stream and would like to share experiences with our doctors from the Peking Union Hospital. So just give me 10 or 15 minutes to answer the questions from the internet. All right, gentlemen? Okay, so it's time for the public. Okay. We have a lot of questions from Facebook, from our platform on Facebook. I will choose one.
I'm not aware.
Okay.
Okay.
They have a lot of questions, but I think because since I've been working here in Wuhan for more than a month, I believe some of the questions can be answered by me. but anyway, I will pass that question to our professionals. Did you find the remedy for the coronavirus? Obviously, the answer is no. The remedy for the coronavirus? Oh, the remedy to cure the disease of the COVID-19. I think that would be more understandable.
Frankly speaking, at present, we don't have a specific treatment for the virus, but the comprehensive supportive care is critical for the treatment.
Okay, so that's a question from Diane Albert Boussan. All right, and the other one is Koirala says, "Congratulations, China! You defeated the virus." I thank you very much, but I'm afraid we cannot say we have defeated the virus. All right, COVID-19 positive, all cured. All right. Okay, more questions from our friends on Facebook. All right. This one, Mary Anak Gordon-Riak asks, if patients cured from coronavirus, is it possible that the patient can get it again, can be affected again?
I want to share with you a positive news or a cheerful news. A recent study conducted by Chinese colleagues shows that infection could not occur in the virus-infected rhesus macaques. The monkeys produced antibody at the early stage after the primary infection. With re-exposure to the virus, the monkeys showed no recurrency of COVID-19. I think it's a good news. Yeah.
Okay, good. Thank you very much. We're having more good news
Yeah.
day by day. Yes, especially in the city of Wuhan. We're expecting tomorrow there will be no newly increased number of the confirmed cases.
Yeah.
All right. Another question from Janet Neha on Facebook. What do you do to improve the immunity of these patients? Is that a question appropriate for you three? Or do you think you can answer that question? Or at least you can give some information, necessary information.
Okay, maybe I can give some advice. I think this audience is asked about just not the patient, maybe the healthy people. So, so that is adequate calorie intake, adequate exercise, and to isolate from the suspect or documented infectious. Okay, but I have to say that for the patient, especially for the critical care patient, still sufficient calorie intake and maintain the internal environment stability and do the support therapy is very important for this patient. And as well as this support therapy was established, the immune system of the patient can recover.
I can give some more questions. I think everybody are sensitive to the novel coronavirus, including me, and I'm health provider for a lot of confirmed cases patient. So, and I don't have enough time to exercise every day recently. But so I just want to emphasize the self-protection and isolation is much more important than increasing your immune system.
Okay, good. Thank you very much.
Can I have another question from this side?
Okay, please do.
Okay. Yeah, so I'm Dr. Tao. I'm the chair of pathology and chief of pathology at McGill University Health Center. And the question is, the treatment with the patient serum that those patients recovered, you're using those the serum of those patients to help the sick patients. Was that effective?
In our protocol, the plasma treatment is only for these patients whose nucleic acid analysis is still positive, or the clinical physicians think these patients have confirmed anemia. And we didn't match these patients because our patient, when the patient get to the severe or critical type, most of our patients, the IgM of these patients are positive. They don't have any virus, but they have antibodies.
Yeah.
So we don't have that experience. But in the report, some of these patients on the plasma treatment can improve.
All right.
Is there a risk? Is there a risk of doing so by using the patient serum or plasma?
Of course, transfusion the plasma is one of the risks. But in the clinical practice, we have all the patients red blood cell or platelet, and we do all these transfusions. So we don't think it is a big problem for the hospitals. But I wonder if you are asking whether these recoveries, they have virus in their blood. Is that your consideration?
Or some other things of the blood transmitted diseases or something.
We do have tests for common blood transmitted diseases to reduce the risk.
Thank you.
Thank you very much. Okay, a few words for our audience. If you have any questions for doctors and COVID-19 experts, please leave them in our FB, Facebook comment section below, or use hashtag #MyOpinionOnCovid-19 to share your views. CGTN will take a question to the professionals and discuss them in the upcoming live stream. All right, one more question is from a professional. This is a professional question from Britain. Oh no, in New South Wales. Oh, that's not. Joseph Wong. Joseph is a GP in training. I think being trained in New South Wales, Australia, and he has two questions. First of all, thank you very much, doctors. I will pass his sincere thanks to our doctors, and then he would like to know what are the symptoms most specific to COVID-19. If tests are in short supply in the community, how will you choose who should receive testing? Okay, the first question. Okay, I will give you the question first one. Okay, first one. What are the symptoms?
symptoms. I think the fever, dry cough is usually the common symptoms, and maybe you have fatigue, you have pain, headache. But I think recently we have in China, our colleagues and some Chinese doctors have published a lot of case cohort in the Lancet. So, and it's free to download. You can see from the literature. Because I downloaded the literature from the website and read the whole story.
Okay, for the test capacity, I think I have a valuable experience I want to share with you. Here in China, patients with both the epidemiological histories and clinical manifestations can be diagnosed as suspected cases. With the suspected cases diagnosis, medical staff will immediately isolate and those cases in a single room. And suspected cases will also be transferred to the designated hospital as soon as possible. And also, people intimately contacted with COVID-19 patients or those with positive results in common respiratory pathogens test, such as flu, are also recommended to conduct the pathogenic detection of COVID-19 in time. So I think with the suspected cases diagnosis, it's really important for the epidemic control.
Dr. Xie, do you mean that we don't have the problem of short supply of testing kits or testing equipment, testing resources?
During the early phase of the epidemic, we do have the shortage of the test capacity. But now we have the testing capacity for including personnel and PCR kits.
Okay, good.
Yeah.
And we are also trying to help other countries
Yes.
who are short of the testing capacity as well.
So for the countries and regions with lack of the capacity of testing, I think you can also use the suspected cases diagnosis.
Okay,
Yeah.
that's a very useful advice.
Yeah.
All right. Okay, one more question from our friends on the internet. Phil Black on Facebook. At what stage should patients be hospitalized? What kind of patient should be sent to hospital? Fever, the temperature, or 37, 38?
I think fever, the onset of the fever is not the
It's not
another sign. Not the sign you should be sent to the hospital. You can stay for a couple of days in self-isolation in your home, but do not get out to infect the other people. But if the fever lasts like more than 5 to 7 days, cannot be cured by yourself, and I think you need to go to the hospital and get the test. And the second, I think the most important thing is the short of breath. Short of breath. Dry cough is not a sign, but short of breath, yes. Short of breath, it means you may develop hypoxia, and you may have, acute lung injury. So you don't have enough oxygen to make you step forward. So that's the important sign that you should be sent to the hospital.
Okay, thank you very much.
So this is a very critical information for Peter and Paul and Matthew, I guess.
Yes, and I have to emphasize that for some severe patients, maybe only the massification is short of breath. Maybe this patient don't have fever, or just have moderate to low fever. So short of breath is more important than fever for this COVID-19 disease.
Okay. Another question from our friends on the internet is concerned to the virus itself. I wonder how much you know about the virus, because the most people said this is a brand new virus. All right, I will read the question for you. It's from Kamanzi Prince Blaze. The question is, how long the virus can survive in the air? I think that's maybe that's not a very good question, but it seems it sounds quite important to the people the people who are not very familiar with the disease. They are still doing their preparations to meet the challenge. So, just please go ahead.
I think it depends on the environment of the site where the virus is located. It's from several days to several hours.
Oh, I see. All right. But the critical thing is to keep hygiene.
Yeah.
To wash hands.
Yes.
To wear masks.
Yes.
To keep distance from people.
Yeah.
From other people.
To
or
avoid a place with limited air circulation.
What about having food, or having food together with other people? We Chinese people share food from one plate. Well, there's not an adequate answer for that, obviously. Okay, we are running out of time. Okay, I will let me check with our professionals from the Canadian side. Do we have any more questions from our doctors of the Peking Union Hospital? If not, we'll pick up.
I have to leave for another meeting in a few minutes. I just wanted to thank you so much for taking the time to share your experience and knowledge with us. It's very much appreciated.
Okay, good. Thank you very much.
Yes, I echo that. That's Peter Goldberg. Thank you very much. I really
All right. Oh, sorry. He's off. What about Dr. Paul Warsowski? Hello. The network is not that good. We cannot hear anything from the other side of the internet. Okay. Anyway, we're about to finish. Just last question. From Sonic Hedgehog. Would breathing in hot steam or air, like in a sauna or from a kettle, help kill virus in lungs? if heat kills it. So.
Oh. I don't think so. It's like you can dry hot water, you can kill the virus. It's the same question, but the answer of those questions is no.
All right.
No way.
If I change another way to ask the similar things, do you think that weather change? Do you think the temperature rising would stop the spread of the virus?
We don't think so, because there is no evidence to show that the temperature raising is going to control the virus.
Okay, good. Because it is a very popular saying among even my friends around me, where they say they're all expecting the summer is coming and everything's gone.
We don't think so.
Okay, that's very useful. All right, I think time is up, and thank you very much indeed for your advice today, given to the professionals in Canada, also to our friends on the internet. I know you've been working very hard during the last months, and during the daytime you have to work, and thank you very much for your precious time. I hope you can enjoy a very good evening and have a very good rest, so that you can work even better. I know that some of the medical teams from other provinces have gone back. I wonder if you can leave soon, or you have to stay here for some more time.
we would stay here for more time.
Yes.
And we also thank all your staff, your team, for your wonderful organization for this kind of conference.
It's my
Thank you.
great pleasure. It's my great pleasure to join such a professional dialogue, which I don't understand at all. But anyway, it's quite useful for both of us, for both the professionals and the people on the internet. Thank you very much again. And this is Xu Zhaoqun doing the live stream for CGTN with the doctors and from the Peking Union Hospital, and we'll do another similar live streaming tomorrow about traditional Chinese medicine. Well, thank you very much for attending. See you tomorrow.